sources. If I would like to go by car or by motorcycle, or even if I choose for a healthier using bike, but there is also some consequences, some risks. But behind this, it is a mobile phone, and in this mobile phone, they already uh, uh, power on the GPS and everything. The data collected by in Indonesia, it is recorded that 133% of mobile phones, the number is bigger than the population actually. So I think because of this data, and then Google could provide services to us, and we are using this every day. And we are not only using this kind of big data services so far. If we would like to go, for example, to hotel, to choose hotel, we are also using this kind of technologies. If we would like to go to somewhere else using a flight, we also use this kind of technologies. My question is, if I would like to go to the hospital, whether I choose this way, whether if I already have this kind of symptoms, I have this kind of cough and also some blood pressure raising or whatever, whether I put this one as this is my this is my condition, and then the outcome or the target is no cough anymore, I'm healthier, I could run like Muhammad Zuhri 100 meter less than 10 seconds, for example. This is my goal. Whether we have this kind of tool, so far probably not, but I think there is always. But then if there is some kind of tools, then there is. For example, today, if I choose the wrong way, and then suddenly there is accident, and then I come here very late, more than 30 minutes, whether I will show Google? No, because actually I already use this kind of recommendation. But if we use this kind of tool for help, whether we will show the provider, you provide this kind of hospital to for me, but then later on this hospital not providing good services, even there is some medical error or whatever. So this kind of something that could be happen, and it is also ethical issues that could be confronted by our community. So actually, if we are talking big data in terms of research, what is the situation of big data in our medical education research? Just started to search on Pubmed using big data on title or abstract. We can find right now about 5,000 articles in Pubmed, and the number is increasing. And interestingly, that there are several keywords or medical subject headings that are more prominent, like data mining, database, algorithm, software, genomics, neoplasm, social media, or whatever. So many researchers already studying big data for a different perspective, using different topics for research. And if we would like to make it more clean, actually we have 4 clusters of big data research in Pubmed so far. Using Force Viewer, we can have this red cluster, green cluster, yellow cluster, and blue cluster. What are of this cluster? The red cluster, more about general research on big data, biomedical research, and then big data from United States mostly, and then social media. In green, mostly about molecular biology, biobank, and then genetic expression, phenotyping, etc. It is also part of big data research. And then the blue one, it is related to several clinical aspects of big data, cardiovascular disease, prognosis. And then on yellow one, it is more from the perspective from our colleague from informatics. Several methods to analyze, to produce new software prediction using big data. So there are a lot of opportunities. But if we are looking more detail from this Pubmed, I think most prominent country are United States, China, United Kingdom, Netherlands. Also, there are many research, but limited research from Indonesia. But I think it is also part of, I think it is trigger for us. Indonesia as the fourth populous country in the world, and I think many ethical challenges on big data. I think this is also trigger for us. We need to do something. We need to do more. We need to do more research and development, something that could produce many benefit to our population. So this is the 2017 survey from APJI. APJI is the Association of Internet Provider in Indonesia. Right now, about more than 100 million of Indonesian already using the internet, and this number is a huge increase from only 25 million in 10 years ago. And most of them are young generation, and they use internet daily, and most of them are smartphone users. And interestingly is that 50% of them are using internet for searching health information. So I think it is also important data that we need also to consider this, and we are part of the health community is a very important of the current situation, the increasing penetration of internet, increasing more access of internet to many people, that many data becoming more and more available there, and we can also use this one for any kind of research. So in terms of big data, I think from the evolution of research, I think we are also talking about the such kind of evolution in terms of the way we are research, the way we are thinking, the way we are practicing medicine, in which formerly we are talking about evidence that mostly collected from traditional sources, but right now we are also talking that there are many digital sources that could be used, and even the number are very huge, and it is also important. When we are talking in terms of traditional evidence, usually collected from high level quality research from RCTs or everything. But this kind of data that are collected by people every day, it is not it is not coming from this kind of very high quality mechanism, but the data is there. So with the existing technologies, software, and any kind of methods, we can also use this kind of data. We can also try to make it data more clean, so we can use it the data for producing several conclusions. So actually, we are starting to move not only from using the traditional evidence, but also using the real world evidence. Real world evidence is something that are coming every day without from a very specific method or ecosystem, but this data coming every day. BPJS Kesehatan collecting every day claim data, and then many other data are already collected from existing research in many kind of institutions, but many more are available not from our institution, and this data is also important for us. So when we are talking about this kind of type of data, we can have genomic data, electronic health record data, many more in many hospitals right now using electronic health record, and then point of sales data. Many pharmacists, apothecaries right now also using informatics tools to collect the number of people buying certain OTC drugs or whatever, and the data is available. And also social media, patient also share to others, I'm sick today, and then this number, when we are calculating about the huge number of population, it also can be another data source for surveillance. So I think we are talking about the increasing number of data that could be used for any kind of purpose in health sectors. And uh, and now, and when we are talking about the big data, actually the key is the volume. We are talking about the more and more data available, and when we are right now read many papers, more and more papers are also consider and using a huge number of respondents that have the opportunity to be accepted. Then just a small setting study with a low number of respondents. And when we are talking about the Indonesian healthcare ecosystem right now, started by 2014, we have just launched the Universal Health Coverage Scheme by single payer. BPJS Kesehatan has just started. They are working together with right now 2,400 hospitals and about 23,000 of primary care, either puskesmas, family physician, or clinics. And in those type of healthcare services, either for primary care services or secondary care services, BPJS Kesehatan already provided with information system for primary care. All primary care right now using PCare. PCare is a cloud-based system provided by BPJS Kesehatan. And from 23,000 of primary care, BPJS mentioned that only 11% that could not use every day or daily due to the limitation of infrastructures or internet connection. In hospital, all claim right now using a software in a CBG software, and it is already collected electronically, and the data available in the data center of BPJS Kesehatan. And interestingly is that the BPJS also provided an apps. I do not know how many of us already installed these apps. Mobile CKN is an app that could be used by member of health insurance to access the history of visit. Even we could also change the primary care membership, for example, and also pay the premium using this kind of apps. And those who download these apps already 3 million. 3 million is quite similar to the number of one country like Singapore. So we are talking about the number of people using this kind of apps, and data probably already collected there, and it's also another source of data. So when we are discussing about this situation, many mentioned that Indonesia is also an digital archipelago. It is an archipelago where many people are internet savvy. Even if we have, for example, our battery is very low, we are very, right now I think it's becoming 6, sometimes becoming the heartbeat increase due to our battery low, for example, or our battery already good, but there is no internet connection. Sometimes we feel isolated. So I think it is also another characteristic of Indonesian. But interestingly, that this number, I think it's also part of our opportunities to see how the netizens discuss, share, and also talking with others could be also another source for data that could be used by researchers in health. This is among the research that we have published just recently. We studied about Indonesian people searching for demam berdarah or dengue hemorrhagic fever. And we validated this data with the Ministry of Health surveillance data from 2012 until 2016. And as we see from this graphic, we know that the pattern of the increasing number of people searching demam berdarah is similar to the data from the Ministry of Health surveillance data. And increasingly, some data, especially when the increasing rates of a number of people searching for demam berdarah, it is sometimes started earlier than the data from the Ministry of Health. So what does it mean? It means that if Ministry of Health also consider this kind of alternative data, not official data that should be collected by all healthcare facilities due to the regulation. If you have this kind of patient with potentially outbreak situation, should report. But actually, people with dengue hemorrhagic fever, when they come to the hospital, it is already several days after the first incubation period. But the people who search for dengue, probably they search this from the first day after they got fever. After fever, and then they took some medicine and it is not cured. They already search, asking whether whether I've got infected with demam berdarah or not. So actually, if we are talking this kind of opportunity, there is opportunity, and also not far from this year, I think early this year on January, many publication mentioned, but we are several area already outbreak of demam berdarah. But actually, data from Google Trend show that start by November, the increasing number of demam berdarah in November 2018 is already similar with the peak of data in 2017. So it means that if we have limited surveillance system with I think the timeliness or the completeness of data, why don't we try to use this one? I think this is also among the opportunity when we are talking about big data for surveillance. This is also another story, interesting story actually. It is not about communicable disease. It is about kanker payudara or breast cancer. This is data 2015, 16, and 17. Actually, most of the data is quite stationary. But then, why there is some peak here? People searching for kanker payudara have a certain peak on, what do you think? Whether breast cancer is outbreak? No, it is not a communicable disease. So what do you think? Campaign, interestingly, it is not about campaign. It is not at all about campaign. We have October Pink every year. This month is a month for campaign of cancer. But during that October, there is no increase. Celebrity case, public figure with a certain disease and already covered by media, and then people looking for it. So it is also the question to our population. Why in the campaign month, there is no increase number of people searching for health information? Probably we need to change the way we pray to the God. Please, God, who are the public figure, have this kind of certain disease so that people will. No, I don't think we need to pray like this. But why many health calendar day did not produce this kind of people seeking this health information? And I think it is also another big question whether this calendar health day and certain promotion and then change the behavior. It is a very long story. So I think this is also part. If we could use this kind of data and then try to use this data to monitor how good and then how far our program reach the population, because our population right now are more and more using this kind of technology. So I think there is also opportunity. And we are talking also about this kind of digital transformation. I think many health facilities already using this kind of PCare cloud-based system. But several issues actually related to the completeness and data quality. It is a very important. And just recently, about 2 months ago, BPJS Kesehatan just released, have you ever heard, some of you here, BPJS data sample. What is BPJS data sample? BPJS data sample is, I think, about 2% of total data BPJS coming from claim that already anonymized, and it is provided for universities and researchers to analyze. So it is actually only coming from 1.6 million member of BPJS Kesehatan. But I think it's also a good data source for research. Even we are using this kind of 1.6 million members, if we are using our own computers, I think we need to have good memories and also good processor to analyze. But the issue is actually also related to the completeness and also the data quality. And I think this is what I mentioned before regarding the, sorry, what time? I still have time, okay. I'm worried always. Sometimes I could not. It is also something that we have right now in mobile JKN. In mobile JKN, if you use mobile JKN, you can see also the history of your data. And this data, I think it is also something for me. It is a very good. Why? Because in regulation, our own regulation is the medical record regulation in 2008. It is mentioned that medical data is owned by patient, right? But then the physical medical record is kept or stored in health facilities. But actually, when people would like to access this one, it is very hard. Sometimes we need also to have a request, several procedures, or whatever. I think it is like many fans of I think several singer or whatever. They love this singer, but they cannot be together with them. Bisa mencintai tapi tidak bisa memiliki. So this is the way that we have actually we have the data, but we cannot have this data because several procedures. But using this kind of mobile JKN, actually we have the yes, we have the data and we can access right now the data. I think this is important. And interestingly, right now the data is probably not kept by health facilities. This data is kept in the BPJS Kesehatan. This data is probably kept in the data server of certain IT provider. But it is not under regulation so far. But I think it is interesting when we are talking about this right now, the electronic data. And I think when we are talking about selamat pagi Prof Rika, mohon maaf. And when we are talking about the situation of big data, we need also to consider that in Indonesia we have also confronted and challenged by this kind of inequity of health development from many districts, and also inequity in terms of the digital access. People in Java, I think, are very happy they could have this kind of 4G, but when you go to many eastern part, I think you can be someone very different. It is not very connected easily with your friends. And I think it is not only about the data itself. The data will not speak, I think, in I think speak for many users without the support of technologies or machine or algorithm. So usually we collect the data, and then our colleague who are also very expert on certain algorithm and methodologies, and then they will develop several methodologies to detect, to learn what are the features of these images, and then finally they produce this kind of algorithm, and then when the new image is coming, without the human, the computer will detect. So I think several studies already start this one. Our colleague in parasitology department working together with our colleague from the Faculty of Engineering also try to identify microscopic images to identify whether what type of plasmodium in this kind of microscopics. And later on, probably we don't need this kind of microscopics. Is it true? Yeah, probably. But I think this is also the issue of whether this kind of technology will change the role of people. I think it is not to change, I think not to make the microscopists not in the health system anymore, but the microscopists with this kind of support of technology, they could work better, they could identify better, they could perform better with this kind of technologies. But there is also some other issues. What is? Actually, regarding the data that are collected, if we develop machine learning in certain area with a certain types of plasmodium, but then in other area, they don't have this kind of plasmodium. Whether this kind of technology, when we transfer to other places, they could identify the accurate one. I think it is also the issue regarding transferring the technologies from one places to other places. And we need also to make sure those that develop AI, artificial intelligence, they should mention what are behind the black box. How to detect this kind of features, what are the data that already collected, whether the data supervised or not supervised, what kind of the algorithm, everything, so that the users, when they use the technologies, they know why these technologies are not perform well in certain area compared to other area. This is, I think, among the ethical issues that I think we need to discuss more when we are talking about the big data later on. So regarding this kind of framework on how to implement the digital health, I think we need to consider also this framework from WHO, ITU. I think in 2012, they released the e-health toolkit in which they mentioned that 7 components are needed to ensure the success of digital health. And I think when we are talking about this kind of ethical issues, we are talking about number 6 and number 7. Number 6 is related to the legislation, policy, compliance, and I think it is also very related to the ethical issues and also the workforce. Because the workforce, the doctor, health professionals, and other are work comply with certain rule, and it is also part of the rule is also the ethical and also the I think consensus among the professional association. And I think in Indonesia, not like what I mentioned before, it is not only about the technology, but also the capacity of organizations and also the digital infrastructures. So when we are implementing this kind of digital health, the area, for example, in certain hospital with world-class hospital or something, because people with a good capacity and also the digital technology already there is a very different to our colleague working in a very remote area, no digital technologies and limited competencies of human resources. And right now, I think we are also confronted this kind of technologies. Mobile CKM from BPJS Kesehatan, Ministry of Health developed this kind of Sehatpedia, and also the private one from Halo Dokter, Halodoc, and everything. Interestingly, this group actually the one that very much popular. Halo Dokter or Halodoc, every day they receive consultation about 5,000 until 10,000 per day. When we compare to Sarjito, how many patient ambulatory per day? About 1,000 or 1,500, I think. So this app, they receive the teleconsultation 3 times higher than Rumah Sakit Sarjito. So we can imagine, right? So that this is also something that we need to consider, that this kind of technology is already using a big data. Actually, next week, I have already proposed research together with Halodoc, and they invited us to discuss whether they agree for studying the data in Halodoc. And last month, I visited Taiwan, and in Taiwan also there is also something very interesting. They have a ATM Health. Any ATM Health, we can use our ID, and then check, and then we have the dashboard, and then in the dashboard we can compare with people already use this kind of ATM Health. And then after using this ATM Health, we can have some suggestion, because this ATM Health is provided in convenience store, sometimes also provided with recommendation, like Prof. Gandes mentioned, recommendation to buy something if you use this kind of ATM Health, and then with certain discount. I think it is also interesting business model. And in Indonesia, they have also this kind of technology, but it is not so far implemented in many ways. Later on, I think, yeah, WhatsApp, I think something that's quite common. I think it is very important to discuss, because we discuss many issues related to the digital health innovation, and then how this digital health innovation could change the behavior. But to become people change behavior, there are several requirements. whether people agree to adopt, adapt, and finally use, or people on the other way around to reject this kind of technologies, and then some norm and social conflict probably, and also the consequences, intended or unintended consequences after this kind of technology. So I would like to go to this kind of, I think several weeks ago, it was also quite common, 10 years challenge, right? In Jakarta rail station, I think 10 years ago, there was many kiosks like this, but right now the kiosk is self kiosk, I think. And also for photo box, also we see that kind of changes. And how about this? In China, they implement this kind of photo box, but in Taiwan, it's only just ATM, very simple. But this one, we inside, we can also consult to the doctors and everything, and they provide free consultation, medical guidance, etc., etc., etc. So my question, whether in Indonesia, how many years we will have this kind of situation, whether change or not, and I think ethical issues will be part of this scenario. I do not know, but Ibu Kandes mentioned that it is also something happening right now. So many, I think it is already discussed. One of the paper, I think recently in Nature, mentioned that there are 5 scenarios on artificial intelligence to be implemented in medicine. And from, for example, full automation until no automation at all. And he mentioned that probably the good scenario for us in medicine is either a model of system that support doctor to perform better, partial automation, conditional automation, or high automation, in which in the hospital very different from one specialist to another specialist. So I think this is also some technologies that already discussed, and also artificial intelligence could not change. Could not be used to certain psychomotor, I think, competencies. I think many surgeon also, it is not easy to change with kind of artificial intelligence. I think, yes, in Indonesia, I think it is also part of when we are talking about industry 4.0. For example, this is also a good example. Telemedicine has been dreamed by many people about, I think, 10 years ago, but it is still very limited to be implemented so far. And then when we are talking about ethics in this kind of big data, I think we need also to consider the ethics either from the point of view of healthcare, ethics from the information professionals, and also ethics from the software developer professionals. So right now also beginning more and more people would like to focus. I'm a data scientist. Data scientists should also consider about the ethics on how to develop the technologies, and then later on implementations. And then International Medical Informatics Association also had this kind of code of ethics. I think it's also very important to be part of discussion. And then the principle, I think Prof. Dick will discuss later more detail about this kind of ethics, and all the principle, autonomy, beneficence, impossibility, and integrity, and everything. I would like to skip this one, but I think the final one, there is also a good paper mentioned about the big data and big problem. So there are also some problem that will come up if we don't think very detail about the potentiality of big data. So I think we need to have, for example, cancer team, when they would like to have this kind of digital technologies, they should also have not only the technology, but also people with ethical principle and everything to become a better team that perform better compared to those without any technologies. So right now, many people are talking about ABCD. ABCD is A is artificial, B is blockchain, C is cloud computing, D is big data. I think we need also another acronym, not only ABCD. What is EFG? It's EF ethics, F financial issues, G governance, and H is humanity. I think that's all. Thank you very much.
Thank you, Dr. Anis. That's a good acronym. Like, why don't you put it in the slide so that it can be more popular? So, questions, kami buka diskusi, langsung pertanyaan, klarifikasi, comments, kami persilahkan. Dalam bahasa Indonesia, monggo. Or Prof. Dik, would you like to come? Oh, Prof. Rika.
Thank you, Pak Anis, for the very challenging but also stimulating presentation. I would like to ask about the future of our Indonesian Revolution 4.0 regarding healthcare, and also related to the research activities that globally have been done is about genomic, post-genomic era. This is about the genomic data. Do we already have national identity regarding what we call it part of the global alliance for genome healthcare providers, because we should come and then we should join this global alliance to be able to get same perception, same things about genome healthcare related to service. So I don't know whether we, Indonesia, already think about that to move to join in the global alliance for genome healthcare providers, because you also mentioned about cloud, how we can keep the data, big data on clouds, many clouds, and how we can talk between, just talk through computers to not only in Indonesia, but also globally.
Thank you, Prof. Rika. I think it is also a stimulating question. First, based on my discussion with mostly with the Ministry of Health, actually, when I mentioned regarding the digital health as the fourth as part of the Industry Revolution 4.0. Genomic and genetic is also part of this kind of characteristic in healthcare, because the data are also quite huge. And interestingly is that as far as I concern, we don't have a certain framework on how to adopt and this kind of potential of genomic genetics, and also how we are working together with a global initiative. But the technologies are there, some services are there, and as far as I know, I think we have already, when Prof. Rika mentioned about the ID, for example, actually we are getting better in terms of using a certain uniform ID. For example, our personal ID right now, I think our country is getting better and better, even though the risks are also getting higher and higher. But this ID for personal, I think, is a very good fundament. And then the second one, we have also the ID for healthcare healthcare facilities. Ministry of Health also developing this kind of ID for healthcare facilities. And then the Ministry of Informatics, and right now it is already changed to the Agency of Cyber and Security, BSSN. They also provided the digital signature mechanism to ensure the security of transferring data from one to another. So when we are talking about the, I think, international level, there is also an agreement regarding material transfer agreement that should also be consent as well. So as part of, if we are working with the national level, in current regulation, it is also mentioned that formerly for health data, it should be safe in our cloud in national level. But then there is a move to change these regulations, not very specific like before. Before, health data should be safe in national data centers. But right now, it is already discussed that health data could also be safe in out of our country if it is not a very strategic and it is very common. It is disanonymized so that it can be used, so we can work together with the national alliance. Formerly, it is say that many initiative in international level, usually the first question from the government, where is the data kept? If it is the data kept in out there somewhere, and then ministry will mention according to the government regulation number 46 2014, the health data should be kept in national data centers. But right now there is a change to move this kind of regulation by providing there are three type of data: very strategic data, and then I think the second one, I forgot the definition, and then the third one is the second one is high risk data, and the third one is low risk data. Low risk data, if it is already pseudo anonymized, it could be used in safe in international data center. So I think this kind of changing in regulation, I think it is very interesting, and it is important as well for healthcare committees to join. And we heard also the upcoming regulation is the new law on data privacy. I think it is also very important. It is not yet released so far. Thank you.
Oh, just one question. The initiative to join the Global Alliance, can it started from your center as an institution, or it should go from international level?
It is interesting, Prof. Rika, because we will, our institution, Gajah Mada, will start to develop our roadmap for big data. We will start with the upcoming workshop. I think we will have 3 workshops on developing the roadmap of big data. I think this issue could be part of the topic on the discussion. Hopefully, in the next 2 weeks, we will invite all centers and department in Faculty of Medicine and also the AHS member regarding the needs on having this kind of big data, and then the roadmap for upcoming years on development, research, and any kind of innovation, including the international initiative.
Thank you.
Yeah.
Thank you, Doctor.
Thank you, Dr. Anis, for the information and yeah, the sharing of information of how far actually we have gone in big data. So yeah, so I was quite surprised myself. Like, oh, we are moving quite. I never imagined that we are that advanced. Well, compared to the other countries, maybe we are still developing. But yeah, in like personally, this is quite a good, like, yeah, it's surprising. Any question? Any discussion, Dr. Dite?
Yes, thank you very much, Pak Fuad, for the very inspiring talk. My name is Dite. I'm from Cebu, Clinical Epidemiology and Biostatistics units. So we are doing many research using the data collected from the hospitals. And we are now having a difficult situation, not a difficult situation, but it is quite difficult to get the data from the hospitals. Although we know that now the Sarjito hospitals are already digitalized, so there are so many data that are already digitalized, and there are so many potential that we could get from that digitalized data, but it's very difficult to extract the data. So we're trying to find a way how to effectively extract the data, and we find a way, we discuss a lot with the division of the information and technology of the hospitals, and we find a way to effectively extract the data. As one of the case, we are now already collected the data of all patients with coronary artery syndrome, acute coronary syndrome from 2014 until 2018, and there are now 13,000 patients. And there are some variables that we are already collected. One of the variable is the medication, and the items of the medication is 900,000 items. So it's quite big data, and maybe it's qualified to be included as a big data in terms of the volume, velocity, or also variety. So my question is, it's very difficult for us in Cebu to analyze that very complex data, and I'm really sure that it could lead to a mistake if we don't know how to analyze the data properly. So my first question is how we could analyze the data properly, that big data. And the second question is how we could unlock the potential of that such big data in terms of the publication research, or maybe to improve the healthcare in the hospitals. Thank you very much.
Thank you, Dr. Tite. Dr. Anis, do you have any suggestion on how to really bring out the potentials of data?
Yeah, thank you, Dr. Tite. I think it is part of I think our concern in Faculty of Medicine. So that's why we will have this kind of workshop on developing the roadmap of big data in the Faculty of Medicine. We are hoping that Cebu will join actively also in the coming. And I think also part of the roadmap, we would like also to identify the existing data set that already collected by many departments, many unit in our institutions. And I think it is also the first start to have such kind of collaboration when we are talking about multidisciplinary collaboration or something. I think it's also very important, because when the first question regarding how to analyze properly, I think we need also to invite our colleagues who are very competent on analyzing big data. So it is a very different compared to the routine statistic data when the number is normally not very high. And also there are a lot of opportunity to use many kind of beyond statistic. So when we are talking about the statistic, usually talking about something that is a very regular, but when we are talking about the many machine learning data mining, it is also to consider to uncover something that beyond the statistic that already covered. I think mostly in our school, many doctors already taught with ordinary statistic, but this kind of statistic that beyond is not actually not part of our curriculum. And so that's why I think we need to work together with our colleagues, especially the group of faculty MIPA, Natural Sciences, Mathematics, and Computer Science, and also group of Faculty of Engineering. There are a lot of people that many times I work with them. Among the question is how we could work together with Sarjito. Actually, they would like to have this kind of collaboration. So I think it is also a very good question. So we can actually, we often have a meeting with our colleague in Faculty of Informatics, and right now we are also working together to start the telemedicine initiative in Kulon Progo. I think we can start later on. If Dr. Dite agree, we can have a meeting together and then try to share something, and then we can move forward. And then related to how to unlock, I think collaboration is important. And then secondly is that our Faculty of Medicine need a good infrastructure for big data. But as you know, here our IT department in library, they only provide IT services for example, library services, and then for e-learning. But this kind of things is a very different. So I think we need also to discuss to Bukandes that we need also IT not only to serve the ordinary IT so far. It is a very different thing. And I think we need also to work together with our colleague in the Pusat data center in Gajah Mada, because there is also high computing performance unit that could be used by many units, and it is still low utilization. So there are many issues, and we need to work together with many groups and colleagues in Gajah Mada.
Thank you, Dr. Anis. My own personal question, very short.
Yeah.
I'm just, because I'm still a very lay person in this kind of informatics world. So you mentioned about data scientists who is the data scientist? Is it the faculty from the informatics? Do you have to be like, who can be the data scientist? Do you have to have a degree in informatics, or can doctor be trained to do a data scientist?
Yeah, right now, data scientist is a term that is a very multidisciplinary term. I'm also joining the group of Indonesian data scientists. In this group, some from healthcare, some from economics, some from social science, because it is a scientist that discuss many aspects of data, not only in terms of analyzing the data, but the impact of the data and also social impact and regulation of the data. They can also mention this one as data scientists, even though their main expert on very specific domain, but they can join together, discuss together with many colleagues about data scientists. So far in Indonesia, actually, when we are talking about the Ristek Dikti, what is linearity, we could not find data scientists, but mostly data scientists are people who already coming from the Faculty of Informatics, for example. But right now, I think the study of, for example, data mining, I think it is just another step from statistics that we have already learned in Faculty of Medicine. So just another course on data mining and also several technologies for artificial intelligence. We can very later on, we can, I think Dr. Vika could not be a layperson anymore in such kind of technologies. It is just move for another step. So I think we can grab this kind of technologies. Like Mbak Nisa misalnya, Mbak Nisa, she's nutrition, but she has already developed not only data, but robotic consultation things, chatbot for diet. So I think in Gajah Mada, I think we don't have this kind of curriculum on developing this kind of technology, but later on she could develop this. I think this is our age.
So health professionals can be trained to become
Sure.
data scientists.
Sure.
If you do
Sure.
training, then
Sure.
okay.
Sure.
Yeah.
But not much detail, but at least we can communicate easily with our friends. So at least if there is technology coming to health sector, we know some basic question to answer to make sure that this technology is valid and could be used by us. Mostly we are talking about the sensitivity, specificity, but we could move beyond and questioning several technical aspects that our colleague in informatics could also work very happily to work with us to produce a very good system and technologies.
Thank you, Dr. Anis. So any more questions? Comments dari yang webinar mungkin? Oh, tidak ada yang dari webinar. Belum ada yang bertanya maksudnya. Okay, so maybe we can move to the next talk by Prof. Dick Willem, and then we can continue the discussion together. Prof. Dick Willem, time's yours. Or maybe you can start with some commentaries about the issues that we can discuss.
Thank you very much. It's really nice to be here. And as you said, many ethicists are a bit impressed by the things that you are talking about. And it's very reassuring if you say that we all can become data scientists. And it's also the other way around. I think everybody can become an ethicist to some extent. And they have to become ethicists to some extent. And I was very happy with your last slides where you said that there should be an E and a lot of other letters after that. But the E for us as ethicists may be important. But it's also true, I think, that this is a new development also for ethics. And I think that up to now, very few ethicists have really got into data science. And to be able to speak about data science in a way that makes sense, also for ethicists, they have to be much more competent in data science, even without becoming a full-blown data scientist. You have to know more about the field that you're talking about. And for me, as a doctor, medicine is a sort of a background that I can easily understand and relate to. Data science is a lot less so. So I'm really speaking a bit this morning as a layperson in the field of data science, although I'm becoming to understand more of it. But I think one of the challenges for ethics is to know more and to become a little bit of a data scientist, even though not a full-blown data scientist. So it's with a bit of, I mean, I really feel like a layperson talking about data science this morning, even though we do some projects and we have some knowledge of data science, but not enough yet, I think. So it's really an area, and I'm very happy to be speaking here because we really need to discuss those issues right from the start, because one of the things that's an advantage now is that we are all at the beginning of all this. I mean, it's a beginning development, and we should start doing ethics really from the start of this technology, so that we don't come afterwards. So we'll be speaking about that a bit. So I'm also privileged because I'm talking in a country here that I read that it is the third most Facebook and Twitter using country in the world. I think Holland is far behind. And when I look around here, I mean, you're still looking at me here, but many people are while they're in conferences, sitting in restaurants, everywhere, everybody is always on his smartphone. I mean, you're 24-hour connected, I think, more than Dutch people are. So and as you said, once there's no internet coverage, people feel really sad and like they're lonely all of a sudden. There may be a lot of people around them, but they still feel lonely. And if I understand your image about the digital coverage of Indonesia, much of this is concentrated on Java. So if you're the third world Facebook using country, it's all concentrated in a part of Indonesia. So here in Java, you must be the number one. So if you look only at Java, you must be the number one internet using and digital people. So the netizens, I mean, that's that you were talking about. So this is something everybody here has. When I give talks about this in Holland, some people still, and I until a year ago, I only had this old-fashioned black Nokia that had this button that had a very small screen, and you could maybe see the time on it, but that was almost everything, and the numbers that you and there's still some people, and even young people. I have a cousin who is what's her age now? I think 25, 26, maybe. Well, yeah. Some how do you call them? Maybe digitarians or they're not eating meat, they're not using smartphones. So I don't know if that development is going on in Indonesia as well, but there's some people who don't like. So, but everybody nowadays here has these devices, and you can do quite a lot of medical things in it. And I will return to those devices during my talk a bit more. Who of you is using health apps of any sort? You are, of course. You're using health apps. What kind of health apps are you using?
Just the mobile TKN and
What TKN is your digital? Oh, that's the, okay, right, yeah. That's what you're using, and that's all.
that's all, but not the other devices like to measure blood pressure or to
Things
measure
like that.
physical exercise.
No, you don't. Does anybody use those things here? Like health, like step counters and and ECG maybe monitors and heart rhythm and like monitoring your food intake and your metabolism and things like that. Nobody uses that here. That's amazing for all the because more and more people are using it, of course, this type of device. So, so just a definition. You mentioned a definition. This is another one. Maybe but they're all similar. Well, when we talk about big data, we're really talking about scale and variety. So it's the number. It's a large scale use of data. So there's enormous amounts usually of data, and they're multidimensional. So they're data about. They may be data about really everything. So it's the scale and the variety that's important. Welcome to the class of master students. So please come in. Yeah, I think you have some. You've already been working this morning, I think. Yeah. So please take your seats. So I'd like to start by looking a bit at why people use this kind of data, this kind of smartphones where you can store medical data and store them in the cloud. So why do they even start using them? I think one of the first thing why people use medical devices on their smartphones is for fun, because they just like to be able to tell other people, maybe through their smartphone, how many steps they took that day. So there are communities where people exchange the number of steps and their heart rate and their blood pressure and things. So fun is the first one. Another reason why people start self-testing on their phones for health risks and health hazards is something that's very strong, and that's anticipated regret. So a reason why you start checking your health is that you don't want to regret afterwards that you haven't checked your health enough. So that something will happen, and we'll get back to that later. Anticipated regret is a very important reason why people start to collect data about their health, want to be screened for health, and why they store all those things. I think one of the other reasons to engage in storing data about your health on your cell phone and in the cloud is greater autonomy, especially when you're talking about stigmatizing diseases. So you don't have to tell them to other people. You can just store data on your telephone and have it anonymized maybe and communicate through the internet. Better self-monitoring is one of the reasons. I think maybe the reason why there's very little use of apparently of health apps here is that you're comparatively healthy. Most of us may be comparatively healthy here. So I think for people who have chronic diseases, health apps are becoming more and more important. So a lot of diabetes monitoring, for instance, is, at least in the Netherlands, is now going through health apps. And there are health apps that also allow you to communicate with your doctor about your diabetes, so about the values that you've registered and how you're doing. So better self-monitoring may be one of the reasons, and it can be done, and that's the big data aspect of it. It can be done on a daily basis and even on an hourly basis. So you can check your blood glucose and do it very, very frequently. So there will be a real-time connection is made possible with your doctor or with someone on the other end of the line who also checks your diabetes data. So there's a real-time connection possible. So self-monitoring might be better. Now, one of the possible, some of the possible issues with using health data on your cell phone is that you may have it may be difficult to interpret the results of the health app. And especially if you look at this type of apps that has that aim to give you, oh, this is in Dutch, but it means my nevus. So there's a brown patch on your skin, and then you can compare it on the app with examples of other of healthy nevus, but also with maybe precursors of melanoma or other forms of nevus that may be less healthy. So if people start to use that kind of apps, it may be more difficult for them to interpret the disease, the results. So there may be unnecessary fears related to the use of health apps. There may be unnecessary follow-up investigations. If you have results that indicate that you might need follow-up investigation, it may be that this is completely unnecessary because it's just a normal variation in a health criterion in something that you like for instance the blood sugar. But it may also be so unjustifiably reassure you. So as long as you get normal results out of your health app, you may think everything is okay, while it's not the case. So it may be unjustified. And it may have some licensing effect. What I mean by licensing effects is that as long as your health apps are okay, you may continue showing unhealthy behavior. So as long as your blood pressure is okay and your heart rate is okay, then you may continue smoking for a while because it's not that bad yet. And that may be one of the disadvantages and unintended effects, and also ethically important effects of the increasing use of health apps and of checkups and things like that. What we call the licensing. There's a very famous opera singer in Holland who is obese and who says he drinks a lot of wine, which is probably true, otherwise he wouldn't say it. He drinks a lot of wine. He's smoking occasionally, he says, and we know what that means. Occasionally means every day. And he does a checkup using health apps and also using other forms of technology. And he's using that technology, in fact, to be able to go on with his unhealthy lifestyle. Because he says, as long as my results are good, I can apparently go on smoking and drinking a lot and eating too much. So that's what you call licensing effects. And because they're inexperienced use and it's not really clear what the usefulness is. And one of the things that health apps would also be able to do, and we've been talking, I think Mugantis has been talking a little bit about that, is that it will change the relationship with your physician. Because otherwise, because previously the physician was the one you could tell your complaints about, and you would ask the physician whether your complaints are significative of some disease or some problem going on in your body, whereas now it's more your telephone that's telling you what's going on. So the telephone becomes a second person in the room, let's say. So the telephone also decides what may be going on. So there may be a competition to some extent between what your phone tells you or what the algorithm tells you and what the doctor tells you. And I'll come back to that because we're starting a project that uses big data where this is one of the issues we want to study, whether there will be a competition between the algorithm and the doctor. So and this is, I think, a few years ago. I think the number is already a lot higher. This was a few years ago. There are about 30,000 health apps that people use to put in information about their health. They're mostly lifestyle apps. So they're apps about the ones that measuring calories, step counters. But there are more and more diagnostics apps around as well, like the one I showed you about skin disease. But they're more diagnostic. Also in for instance, mental problems. So there are more and more apps that allow you to check if the fact that you're not feeling well is a symptom of depression or not? Or is it just not feeling well that will go away, or that has to do with, well, some things in your family that happen or something in your relationship that happens? So, so there are more and more psychological health apps going on, like the screening for depression apps. And they would allow you to see if you're beginning to be depressed. And we don't know the effects of that kind of apps yet, because you know the problem is that if someone doesn't feel nice, and if the screening app tells him that there's a chance that that he's developing a depression, there will be a large placebo effect. We were talking about placebo effects yesterday. So when the app tells you you're going to get depressed, it may be certain that he will get depressed because the app tells him that that will happen. I would call that a nocebo effect. So it's not placebo, but it's nocebo. You will harm someone, so will do harm. So the harm will occur if someone tells you, and especially if the app tells you that the harm will occur, it will occur probably. So those are the probable issues related to this kind of apps, what we call direct-to-consumer e-health applications that have to do with the big data, because it's data that's usually stored on your phone, but also stored in the cloud, and it can be used for all kinds of other. So what we're talking about is personalized iPhone e-health, according to someone, personalized iPhone healthcare. I'm not going to show the film because I had to warn you. And what we're talking about, and I think it's important to make that link, is personalized medicine. And you've already mentioned that, I think. But so the whole big data development is going into the direction of tailoring medical treatment to the individual characteristics of each patient. But to do that, you need an enormous amount of data about the differences between patients and about individual patients. So it's the science of what's called individualized prevention and therapy. And in the beginning, this only concerned, or mainly concerned, genetic data, so data about genetic makeup. But it's going more and more into the direction of involving all kinds of other data about a person. So it may be about genetics, but it may also be about habits that a person has. It may even be about the places a person goes to. So if you use your Google Maps app to go here, then it will be registered. It will be registered someplace. And it may be necessary to use that for personalized medicine, because it tells you something about what a person is doing in daily life. And so the treatment may be adapted to those kinds of characteristics that will be transmitted through your cell phone to some big data storage. And they also talk about Google Medicine, of course, Googleized medicine. So this is, it's also called precision medicine. I think it's significant that there's a shift in words. We're less talking about personalized medicine, we're more talking about precision medicine. So it implies data about the individual, about preferences, about clinical features, medication history, the environment a person lives in, the behaviors and habits of that person, and the biomarkers that are known of this person. So it's a whole complex of data. So in fact, what you could say is that the big data are not only talking about many, many individuals, because usually you integrate the data about millions of people, but it's also big data about one person, in fact, because there's a large amount of data, usually daily, but real-time data about a lot of aspects of one person. So it's really also, we're talking about individualized use of large amounts and a large variety of data. So this is what it's really about. You make up the person from a lot of data, among which the DNA, but also all kinds of data about environment, and that finally makes up what a person is. That's the basic philosophical idea, I think, about what is changing in our concept of a person. I think that's an important thing to keep in mind when we talk about personalized medicine in this sense, in relationship to big data, is that our concept of what a person is changing, is involving a lot of this kind of stuff. I've had this, I don't know why I did this twice. I think one of the ethical issues that we need to address when we talk about big data and the use of health apps in phones and the storage of big data that we do about ourselves is business models. And I think that's another area where ethicists have been not enough involved. I think we should really look at what kind of business models are involved in the apps that we all have on our phones and that we use, and in the data storage that the data storage models. And I think there's a few, you said you don't use them, but if you use the health apps on your phone, they're free usually. Yeah, of course they're free. You would look for, everybody looks for the free ones. And the problem is that free doesn't exist. So there's an old saying there's no free lunch. And it's true, there is no free lunch. Also in the use of health apps and health data, nothing is really free because you always pay with something. And if you don't pay with money, you pay with your data. Or you pay, I will show you the most, but there may be other business. I'm not an economist too. I think ethicists should be basic economists as well. So we should know things about economy. So I think there are three possible business models, and they have ethical implications. And so the first business model, of course, is that you pay for your app. But as you say, nobody's paying for apps, almost. I don't know, who has paid apps on his phone here? Also nobody. Do you have smartphones? You do have smartphones, but you have no apps that you paid for. Yeah. I know, I think the same applies. I think I have one. Yeah, I have a paid app, one paid app. I like to look at the stars at night. And then there's a very beautiful app that you can, but you have to pay for, that will show you, when you keep your phone like this, it will show you what stars are visible in the sky. It's a nice app, but you have to pay for it. Because there's no other business model for that kind of apps. Because they're not interested in, nobody is interested in the fact that I'm looking at the stars in the night. They just let me go. What are they interested in? So, that's very rare. The other one is of course the app is free, but then you have to go through some form of advertisement first, or there's advertisements linked, and they're very, very intelligent usually. So you don't even notice maybe that there are advertisements, or that they push you into some direction. So that's the other one. But the most important one, of course, is this one. And that's the free app. And you may be aware that there's a whole industry of people selling your apps to other people that may be interested in the information that is downloaded from apps is sold by data brokers to institutions or authorities, or all kinds of people that may be interested in the kind of information that is stored on your iPhone. So you should realize that your data, anonymized or not, is sold to institutions or people who want to know about it. So free doesn't exist. And there's one other thing that probably exists less and less, and that's anonymity. I would like to have your view on that, but I think that the more data you gather about a person, the more difficult it becomes to remain anonymous. Even if you take away the name and the date of birth and the passport number and the public service number and everything, just by what a person does, you're able, and how you could, the Google Map thing, if you follow where he's going, you will recognize the person. I've been told by a data scientist in Holland, so I believe it's true, but I'm not sure it's true. I think it's true, that the police, after a bank robbery, they wanted to trace the possible robbers. And one of the things robbers immediately do after a bank robbing is they throw away their phones because they know they can be traced. So they throw away their phones into the water, probably. And then 5 minutes later, the police knew where they were because they had a new cell phone. And that cell phone displays exactly the same trajectory as the old one. So they recognized the person by tracing the cell phone and tracing the trajectory and tracing what he was doing. So so anonymity with all these data that come from your phone, with the big data that come from your phone, it gradually becomes an illusion. I think we are all traceable even without our passport number but I'm not sure. I may be too pessimistic, but there's a lot. So this is the Apple Health Kit. Apple's is until now was one of the most transparent companies about what they did with your health data, but so you had to agree that your health data were used in the Health Kit, but they were using them. So Apple is one of the big, of course, the big data storage places where there's a large commercial interest in using your data. So that's about, and what we're doing. This is a movement. This is in Dutch, but what it's about, in fact, is about a quantified self. We are moving in the direction where, through what we register in apps and things, we're moving in the direction of what's called the quantified self, in which the self is really becoming a quantifiable issue. So it's quantify. You can really quantify everything through health apps. So I'm going to look a bit away from the health apps into other considerations about big data. This is from a literature review by Yanko, an Italian researcher, and others, that has been published in PLOS ONE not long ago. And they did a literature review of ethical issues related to the use of big data. So how often, which type of issues was mentioned in the literature because there's an enormous literature already available about the ethics of big data. And by far, the biggest issue in there, I think about 200 and 250 articles they reviewed, was privacy and confidentiality. So the use of big data, the main worry is that there is a privacy issue and that confidentiality will be very difficult to maintain when big data come along. So that's the main issue, I think, that we're talking about. And I'll have two examples later on where this also will become a big issue. Another one is informed consent. So, and I think it is one of the big ones too. I mean, I just showed you an image of the health kit. You give informed consent if Apple is going to use your data. But do you know what it will use your data for? Especially after your data has been sold to another company, it will become completely unclear what they do with your data and what they will use it for. They may use it for all kinds of aims that you haven't known, that you haven't ever known. So informed consent is one of the big ones too. Fairness and justice. Well, I think your images of Indonesia were clear. There's a lot of unjust distribution of this possibility. So there's a lot of injustice and inequality in the access to the advantages of big data use, to health apps, but also other forms of big data use. And I was very glad to find trust right high up in the number of ethical issues that were addressed in the literature. And I think trust in physicians, but also trust in the healthcare system, is something that may be under pressure as a consequence of the big data development. Because people will think that whatever they tell their doctor, or whatever happens in the healthcare institutions, will not be protected. So data protection will, and issues about privacy and confidentiality will have an impact on trust in doctors. But also the other way around. I mean, if you discover that your telephone was better, or the algorithm in your telephone was better at making a diagnosis than your doctor, then this will also impact on trust in the healthcare system. So there's two ways. It's about confidentiality, but also about changing roles. Now, there's a lot more things like transparency. I think I was a bit surprised that was small, because I think one of the real big issues about the data that we store is the risks of them being misused. I mean, cybercrime is everywhere. So I think the issues about the criminal use of data are rather unaddressed up to now. And you see that in the literature too. So the hacking of health data, or the use of, or the stealing of health data, may be something that's really important. It's one of the big risks. Now, you can say that in older systems there was always a risk of data being stolen, but it may become more easy, and the amount of data and the degree and the variety of data will be a lot bigger anyway. So safety, I think, is a big issue too. So I'll not follow all these things, but this is a sort of a list of ethical issues that's been discussed in the literature. And this is one of, I'm going to speak about a project that I'm going to give you two examples now of projects that we are doing on the ethics of big data in my hospital. And this is the first one. It's been published as a blog in BMC. And unfortunately, my PhD student hasn't put a picture on the blog. It's always stupid not to put a picture. But Mirika Bak is the PhD student who is doing a project that I'm involved in from ethics. And I think the interesting thing about doing ethics in this type of projects is that you're present from the beginning, and that you develop your ethical the ethical part of the study parallel to the development of the big data. So it's really ethics in big data developments. It's not about, and it's not after, it's while the project is going on. So so this is her blog that you can read on BMC. It's about big data. She says big data, big ethics. You said big data, big something else. Big problems. Yeah. She said big ethics. So it's and it's about this project. This is a European Union funded project about that will gather data. I say thousands here, but it's probably millions, on millions of patients throughout Europe who've had a sudden cardiac arrest. So they fell down in the street or on their job or wherever with a sudden cardiac arrest. And what the aim is to gather a large amount of rather unspecified data about what happened before, about their disease history, about their genetics, about biomarkers, about all kinds of things, and that would finally lead to a personalization of the approach of prevention instead, in fact, but maybe also treatment of cardiac arrest. So the basic idea is that cardiac arrest should be treated in a more personalized way. and prevent it in a more personalized way. Because the problem is we don't know who of the people who have a cardiac disease will develop a cardiac arrest. Cardiac arrest is always falling out of the sky. And this project is intended to change that. And we're doing, while this project is going on, it's, I think, a 25 million euro project. So it's not only big data, big ethics, it's all big money. There's a lot of big money going on here. So the EU funds this project with about 20 million euros, and it's going on in, I think, 12 European countries, where they gather all these data on the people that have a sudden cardiac arrest. And it's, and there's a sub-study, and that's cheap. I mean, ethics is always cheap. You just have one ethicist and maybe a few assistants, and they do the ethics, and then all the information scientists get all the money. You know, the 24 million goes to the information scientists and the cardiologists, but the ethicists, we've just one. But I think it's important that we do that while the project is going on. So we really don't know what's going to come out of this, and what kind of factors will be found to be decisive. So what the ethical issues, and there's one thing I should mention, and that is that big data research, at least in the Netherlands, and I think it's the same in many countries, for the moment falls outside the scope of medical ethics committees, because there's no direct involvement of patients. It's only their data, but not they're not directly involved in the study. So that's why it doesn't fall under the Declaration of Helsinki that I've been talking about yesterday. And I think that what she found in a literature study also on ethical issues, and the kind of issues that we're going to address, and we're already addressing in that study, is that we should find solutions in the study for the risk of privacy breaches. We should find possible solutions to prevent data from leaking, so hacking or other forms of criminal or negligence. There's obviously a lot of negligence going on data, so there should be forms of preventing negligence. We will be talking in the project about how we can prevent genetic discrimination. We will develop a policy about the disclosure of individual findings. So if you store all these data and you find a relationship with the possibility of having sudden cardiac arrest, then that may be relevant for some persons in your group and in the group. So we need to have to know whether the individual's findings from the big data research will be disclosed to individuals. The application of research. One of the big issues here is what can we do with the data of the people who didn't survive the cardiac arrest? So can we use, because these data will be gathered for all cases of cardiac arrest, and some people don't survive, of course. And can we also use data post-mortem, because we cannot ask for their informed consent anymore, because they will not have survived. So one of the issues here is, can you include data about people who died? Or do you need family? Do you need the family for that? Do you need other people to allow you to use that data? So those are the problems, the ethical problems that we want to address during this big data research project. And it's mainly because it's all very new. We've never had this size of project before. So the EU, the funding organization, has said there has to be an ethical part. That was not our invention. In fact, what happened was that the cardiologist who leads the project from our from our hospital came to see me because the EU had said, we're prepared to fund your project, but you have to write an ethical side project. And we're only funding if you also address the ethical issues. And I think the European Union is more and more focused on also addressing ethical issues with this type of big projects. And I'll show you just one example of a similar project that we're going to do, and that's about data mining for cancer diagnosis. And the problem that this project, that's also a 20 million euro project. The problem that this project is going to try to solve is that some form of cancer have very common initial symptoms. For instance, some forms of like pancreatic cancer, for instance, or other forms of gastrointestinal cancers may start with very common problems. And that may lead to a long delay in diagnosis, because they will first be treated for common diseases, as if it was a common disease. So that's a problem, especially in family practice, where you see these people with common symptoms, and they will. So it might, data mining might be a way to get more knowledge about who are the ones who may be going to develop cancer. And so what the project is going to do is to collect all kinds of daily life data, which includes, for instance, shopping data. Because as you know, shopping habits also go through telephones usually now. So there's a lot of data, or to personalized bank passes. All these data are stored somewhere. So, and they may be mined. Even though people didn't give permission for that, it may be possible to mine those data. And they may indicate who, from all the people with common stomach problems, may be the ones that are more prone to develop cancer. So there's all kinds of, but also medical file data from general practitioners will be used for that. And there will be more than 1 million patients involved. Social data, social media data, so where they went, and also like searching habits, things like that will be. And there will also be partly unstructured data. So GPs in Holland, they may just type a text in their file. And that's typically unstructured data. It's thoughts that they have or things they don't want to forget. All that kind of data will be unstructured in there. And one of the machine learning things for the information scientists, the interesting part of this project is that they want to try to analyze that vast amount of completely unstructured data that are they're digitalized, but they're in fact stories about a patient. So that's, and then machine learning should be used to construct an algorithm to predict cancer. So that's the basic idea of this project. And here too, we're involved right from the start as ethics researchers. And the problems here, I think I put something in, no. So here too, the ethical issues are related to privacy, and especially privacy if you look at very everyday daily life data, or about trust in physicians, also about a changing doctor-patient relationship. That's one of the things that will be studied here too. And one of the things that we will also look at is, and I think that's going to happen quickly, is that algorithms like this will also become available on the internet, so that people will start using them themselves. So they will have, when they have a stomach ache, they will have the possibility soon, if the algorithm is finished, to consult it on the internet. And that may have the same issues around whether they are able to interpret the data and whether it will have damage consequences. It may damage them if they see those algorithms too early. So there may be increasing fears around common symptoms, and that may lead to medicalization and unnecessary hospitalization and all kinds of other issues. So that's the kind of issues that we want to study as a part of, and you were talking about the framework that we don't yet have a framework for this, because we're really developing the ethics of this type of research as it is starting to move. And I think that's a beautiful chance. And I think what you should do, and I'm very happy you mentioned that already, is that in this kind of projects, your center should be involved. So there should be a parallel bioethics consultant as soon as you start doing big data projects here as well in UGM. And that's what we try to do in our ethics center, try to be there right from the start. Because otherwise you're only there when everything's fixed and everything's set up, and there will be no possibility to improve things, because it's really about improving things by paying attention to the ethical issues right from the start. It's not about blocking things. It's not about saying what is bad about it and that it should be stopped. It's really about helping to improve a project by looking at the ethical and regulatory issues right from the start. So that was my conclusion. It has only just begun, I think, so we're really in a starting development. And ethical issues need to be explored now, and not when data mining and algorithm construction and everything that's possible has become common practice. So, and that's something we call parallel ethics research. So there should be parallel ethics projects. That was what I had to say about this as a layperson still.
If you're
So thank you
lay,
for
then
your
what are we?
attention.
Thank you, Prof. De Kloos. If you are layperson, then what are we? Okay, questions, comments, opinions? Dalam bahasa Indonesia juga kami persilahkan. Prof. Dick is also interested in learning bahasa, right? So we
Yes,
can speak gado-gado.
Yes, so
I-
yeah, try.
Ya, silahkan.
Okay, thank you. Even though there isn't any framework, ethical framework established yet, what suggestion or advice you can give for the application of big data in research and, of course, in the care delivery? Thank you.
Well, I think we don't have a real framework such as the Helsinki Declaration about research, but as I showed you the graph with the most common ethical issues, and I think you can use that as something preliminary to a real framework. So you could say there are a few issues that you should at least always address when you're starting a big data project or when you're applying that kind of data in either science or healthcare. And as you saw, the main issue is the privacy and confidentiality issue. But I can go back to that graph if you want. So this was the graph I meant. So I think what you could do for the moment is that you should look at privacy confidentiality, and I think informed consent would be one of the basic issues, especially because it will be different from informed consent as you know it, because it's often not really possible to say what is going to happen to the data exactly. So you will have to have good informed consent procedures, and well, I think something like fairness and justice would be really important. So this you might use these 3 or 4 things as a provisional, the things that you need to think about before you start using big data in either care or in research. But I think a framework will come up in the next coming years, because we really need something similar to the Helsinki Declaration, I think, for big data research. Yeah.
Okay. Yeah, so we are not that far behind, right?
Oh,
Compared to
no,
Netherlands.
but you're advanced in some. You have much more of this. And
Um,
no, you're not far behind. We're doing this together. Yeah.
Is there any other question, comments? Otherwise, I will personally raise question. So can you elaborate a bit more about the actual ethics sub-study that is done with the sudden cardiac arrest? Like,
Yes.
what kind of things then? How do you do this ethical sub-study then? Like,
Yeah. It's a study that consists mainly of interviews with people involved, and then you have to think of cardiologists, but also families of patients or patients themselves who have survived cardiac arrest, and so we're going to interview them about the issues that are mentioned here, and what they think about the fact that all their data will be used for personalized medicine. In fact, we'll also interview legal people, so legal people who are legal experts, and we'll talk with them about what the legal framework or limits should be. So we're finally, in fact, going into and what we also do is that we do an observational study. And the observational study is not, we don't observe cardiac arrests, of course, because that's really difficult. But we do observational studies in the field, in the research institutes where the data are used and processed, so that we can follow very closely the discussions between scientists. So when there's a meeting between data scientists and doctors and other people, then the ethicists will sit in to register their discussions and to what they're talking about and how they make choices about what should go into the algorithm and what not, and how it should be constructed. So it's partly observation and it's partly interviews with stakeholders.
so it's a very broad exploration about the kind of issues you're gathering, issues that happens throughout the study.
Yeah, and we will do that in all the countries that are involved. So we'll have interviewers and observers in all the countries that are involved, because issues may be a little bit different in different countries, especially the use of algorithms may be looked at differently in different countries, also by patients and by their families. They may, I think in some cases, patients have less trust in algorithms than in doctors, and in other situations they may have more trust in algorithms than in doctors, depending on their history, of course, too.
Okay, thank you, Prof. Dick. 1, 2.
Yep.
Mas Anies first, and then after that.
Prof. Dick, interesting talk. I would like to ask about two aspects. I think the situation in EU, I think it also influence other part of the globe, including the implementation, the GDPR.
Yes, sure.
Yeah. And just would like to hear your comment regarding the GDPR on aspect on health data and privacy, because it also related to this one. And the other issue, I think it also mentioned in GDPR regarding the right to be forgotten.
Yes.
Because some global apps also right now also mention about people could also have this right of forgotten. But then in the healthcare, whether people could also have to, whether they have also this kind of right. For example, after when you mentioned after they die, then I would like to be forgotten in the hospital. But in Google, they also try to implement, if formerly our historical situation, we have also bad habit, and then we would like to be removed from the Google search, and they offer this kind of things. Thank you.
Thank you for the question. GDPR is a new European regulation on privacy, and it is a lot more let's say, restrictive on the use of personal data than the regulations that we had, and it's a common European regulation. One of the issues in the study is that we're going to look at the question how this kind of use of data can be made compliant with the GDPR. So in fact, we don't yet completely know how this is going to be, because in some aspects, and especially obviously the privacy and anonymity aspects, it may be quite difficult to maintain anonymity in this type of data. So in fact, we have to speak about this in 4 years maybe, when the project is finished. Then we will have found a way to deal with the privacy issue in the context of GDPR. So I don't yet know, but we know that it will be one of the big issues that we have to address, GDPR. Now the other question about the right to be forgotten, we already to some extent had that right before big data, because there was in the Dutch healthcare law, there was this. It was stipulated that patients had the right to see their file and to remove things that they wanted to be removed. And it sometimes happened that someone who had, for instance, a long period of psychiatric disease, wanted, after he felt that was over, he wanted that to be removed from the file, because he didn't want to be confronted with it all the time again. And especially when files became available to more than one doctor, then patients felt that they were confronted with their psychiatric past over and over again. Oh, so they wanted that to be removed. And they had a right, if it was not really necessary information for the rest of their treatment. And that was up to the physician to decide. Now there is a right to have yourself withdrawn from the data. Yeah. And that's one of the ethical issues that we will need to address. How do we, in relation to GDPR, how do we guarantee that a patient who would ask for the removal of data, how is it possible at all to get the data out again once it has been processed in various places? We don't yet know how to do that, and we will be. I think it's a very good ethical principle that people should have a right to be forgotten, but it is technically sometimes very difficult to make that possible. But it's one of the issues that we're also going to address in the study. Yeah, I didn't put it on my ethical list, but it is one of the issues. Now, what we don't know, of course, is how many people will want to be forgotten. Because if you look at the apps on your phone, everybody knows that what you put in your phone goes everywhere. And I hear very, very few people who are worried about the fact that they will not be forgotten. So I don't know if it will be very common for people to say that they want to be forgotten. In previous times, patients who wanted to have things removed from their medical file were really very rare. It happened maybe once every 5 years that someone wanted that. So even though it's a very good ethical principle, one of the things we're asking in these interviews is what people think of this right, and if they think it's important, and if they ever will use the right to be forgotten. So, if that's an answer, we're going to address that, and I think it's an interesting ethical issue.
Yeah, because I heard that in our draft of the upcoming privacy law, it also includes this kind of statement. I do not know the final statement will be like what. I'm not sure, but in healthcare, I think it's also very conflictual situation, especially if the right to be forgotten is because of the doctor examine the person, and it is the doctor's perception, not the patient data. Actually, it is the doctor cognitive result and also other data that it is not only the personal but also other profession.
Absolutely, and so there was a right to have things removed from your file, but that didn't include the thoughts of the doctor. So if a doctor had put somewhere, I think this is depression or whatever it was, then you couldn't remove that. Yeah, you couldn't remove it. But you could remove some of the lab results or things that had become irrelevant. But the part that is the ownership of the doctor, you couldn't remove. Yeah. So I think you can't remove everything. So you will never be completely forgotten, probably. Yeah. And for some people, that's a consolation, and others would like to be forgotten when they're dead.
I think that's why in Muslim we have Raqib and Atid that will continuously recorded everything.
Okay. So next question.
Okay, thank you, Professor. I would like to ask you about the big data in electronic medical records.
Right.
What about the confidentiality and privacy aspect of electronic medical records? Because the use of electronic medical records is way more different than the use of health app.
Yeah.
And also, I would like to ask you what it's like in your country to face this transition from paper medical records
Yes.
to electronic to EMR, because in here in Indonesia we can say that we cannot accept this 100% letter. Thank you.
Okay. Yes. Thank you for the question. It's a very good question. I think we've moved also in general practice. We've moved completely to electronic records. So there's almost no doctor anymore who writes things down on paper, especially maybe the few things that he wants to keep secret completely. Then he may put them on paper, but it's almost nothing. And there has been a lot of discussion in Holland about connecting about the access of electronic patient records by others than the doctor who had it in his computer file. There has been a discussion about, for instance, the need of emergency departments to be able to look into general practitioners' patients' files. And that discussion was about privacy. And it has been a long discussion, and what we now have in the Netherlands is that you can, as a doctor at the emergency department, you can only see very restricted information which is provided by what they call a connection point. So there's connections points that may link to the data in the medical file of the GP, but they will only concern data such as the age of a patient, and medication data, but not a lot of detail about the disease, about the medical history. So they're relatively protected. So there's just the essential data may be accessed, especially medication data, but the rest is now is still restricted access. But the discussion is still going on because there's a need for that information. If people go to different doctors in the healthcare system, it would be necessary to have access to the personal patient file directly. So, and we're still wrestling with the privacy issues that are related to that, especially in the connection between GP files and hospital files. But so that's also a problem. It hasn't been completely solved, but apart from some of the essential data. And that's you're right that that's really essentially different from data in health apps, because that's what you put into it yourself as a patient. Where here it's patient files that are also filled by the doctor. Yeah.
Maybe if we have interested in doing the research about confidentiality and privacy in EMR, maybe do you have an advice for us, for maybe what details that we should miss off, or what details of confidentiality and privacy we should focus on. Thank you.
So when you want to do a study about confidentiality in the EMR,
I think so.
yeah. What kind of data you would want to study? I think, well, that's a big question, but I think, well, and then you would be talking about electronic systems and also about connecting EMR emergency systems to GP systems, you think, or is that not the question you?
In ethical ways only about confidentiality and privacy, because the patient information is also can be accessed to the third parties as company who would the medical records of their employees from the diagnosis of the doctor.
Right. So I would think that you would really have to look at the extent to which personal information about disease trajectory and maybe lifestyle would be available to third parties outside the health system. That's what you're looking at. Oh yeah. I think we have. I think you need to be looking at really very strong restrictions on third parties to look directly into patient files. What we have in the Netherlands is that insurance companies can consult aggregated information on what happens to patients in the ER. So they will look not at one particular patient, but at groups of patients to see what kind of patients come into the ER. But they don't have access to the personal health information of the singular patient. And I think that's one of the real issues. If insurance companies should be able to look into the personal disease information of patients. I think that would be a step too far. Although I understand that they want that because they have to pay for the treatment. So they want to know everything. And I think there should be clear restrictions that has everything to do with professional secrecy. And for a patient, it would be, I think, important to be sure that the insurance company will not directly know what diseases they have. Yeah. So that would be the kind of issues I think you would need to address. Yeah.
Thank you.
Okay. You're welcome.
May I comment regarding this issue?
Yes,
Because I think this issue is very important in Indonesia, especially for primary care level. Because in primary care, all the 23,000 of primary care, we are using the one cloud system from BPJS, the health insurance.
Yeah.
And in health insurance, as far as I know, even without study, we know that all privacy is all violated.
It's completely disappeared.
Completely violated. So that if we study this topic, I think it is a very important result for policymaker.
Yeah.
Because so far as I know, if, for example, if you of us, we lost our ID, and then our colleague in the healthcare, in the primary care, know our ID, they can access directly all our data without any consent at all. So I think this is a very important big issues, and I think this question is a very important topic for research to be discussed. And then the result of the discussion from ethical perspective, we can share directly to BPJS, because nobody talk about this topic.
Yeah.
I think this is very important, and I think later on, if we have this kind of first result, we can discuss also many in the different setting, especially in the hospital. When you mention claim data, many discussion right now is going on between the Medical Doctor Association regarding the letter from the health insurance, whether if claim data is under dispute situation, the health insurance could access all the medical claim data. It is still right now still not solved.
Okay,
so,
it's not so.
Because I think from law it is not very clear, but then from ethical perspective we don't have such kind of many detailed consideration.
No. So I also think, and it's a problem that we've partly solved, I think, in the Netherlands, but to some extent, and there is a limit now, but I think it's really important to look at that. But and there's a pressure from third-party payers to be able to see really everything, because they want to They want to make sure that they pay for the right thing, which you can understand. But there is obviously the professional secret, which is then violated on a daily basis, I think. So information goes out to people who shouldn't see that information. So I fully agree that that's a project it's really important to do. Yeah.
So
Sure.
after this, Zahwa can consult with Prof. Dick and Dr.
Yeah.
Anis.
Yeah.
Yeah, see? So you have, this is important topic and it's to be
I
developed.
think, yeah, it is.
Okay.
Yeah, sure.
Okay, then the third question, yeah.
Thank you, Prof. Dick. It is actually not my question, but there is someone following from the webinar. Webinar, yeah. So
Can they
my
not jointly
colleague,
as? Can they not? Oh,
I
either.
don't
Okay.
know because
If
I
it's
don't-
not possible, then
yeah.
Dr. Tiwi can.
So
We have
yeah, so
participants joining.
Yeah, participant from the webinar. So from the Fable company, one of the startup company in Jakarta, and they are planning to have a collaboration with the BPJS, with the JKN. And the question is, can we implement the blockchain technology on the big data healthcare to provide confidentiality, transparency, and also privacy of the patient data? Maybe your comment about it.
I'd ask you.
Thank you.
I know little about blockchain technology. I have no
Or
idea,
maybe
really.
So
Pak Anis.
Pak Anis should answer that.
I think if the question is can, yes, can.
Yes.
Because the technology is there, and also the blockchain technology could be studied, could be piloted, could be experimented. I think it is possible. And in several research also has been published as well regarding blockchain for medical record, because it is also a new way to provide more secure and also decentralized system. And there is also opportunity that patient or healthcare provider, they could develop the specific rule, which one that could have right to access this data. It is belong to the users and owner directly of the data. So I think it is important. And then with regard to whether BPJS, I think we need to talk with them. I think they would like also to, after the discussion here from the first our participant regarding the privacy issue, I think many already knows about the violating situation in PCARE. I think BPJS will be very happy to receive this kind of topic for research and collaboration.
Okay, thank you, Dr. Anis, and for the answer. And would Prof. Dick add comments to that?
I'd only be very happy if it's possible to do is to solve one of the biggest issues through this type of technological possibilities.
Yeah.
It would be very good. But also there, I think we should look at the ethics of all that. Continue looking at the ethics of the use of blockchain technology as well. Yeah.
And I think one of the interesting part is also to study about what the perspective of the patient, knowing the kind of system that is going right now, like how are they aware about the things that's going on, that their information is violated and stuff like that. I think that's also one of the area that can be explored. Yeah. So ada pertanyaan, diskusi, komen, tambahan tentang big data? Yeah, Opi? No. We still have 20 minutes. Do we want to finish early, wrap up early, or is there still open? The opportunity is still open, but otherwise we can wrap up. Prof. Yati, Prof. Narto, or Prof. Rika would like to have some final comments regarding the big data. Okay, Prof. Narto.
Ilmu mengeblok tadi. Ini kalau apakah itu bisa diajarkan secara umum di universitas, di fakultas kedokteran apa kesehatan itu khususnya? Kalau ilmu ini ada, mereka bisa juga punya privacy istilahnya untuk apa yang dia publish, apa yang dia pikirkan, yang mungkin direncanakan ke depan untuk publikasi, jangan sampai diambil orang, diblok dulu gitu. Itu bisa diajarkan.
Kalau platformnya sudah ada sebenarnya, platform yang yang generik yang bisa dipakai. Jadi generic platform for blockchain technology could be implemented in any kind of business model. For example, either in healthcare, either on finance, either for academic, we could apply this kind of method where the owner of the data is the one that have the authority and autonomy to define whether I would like to share the data to others or not, because yes, if to whom the data could be accessed by certain people and what level of data that could be shared. I think the essence of blockchain technology is like this, because of the current situation. Many are actually worried about all data are becoming nobody's data, because public data, sorry, because everything become public. But the idea is available, that the generic platform available. And then I think if we would like to have this kind of a specific business model, for example, for academic purpose, for example, usually in academic setting, we have the idea to develop certain research, but then this idea is not very clear, and then we would like to discuss, but then the discussion should be closed in separate group before later on the discussion could be improved until a proposal or whatever. But sometimes also consider about, we do not want to be these ideas stolen by others. So I think this kind of, because using this kind of WhatsApp, actually we do not know how many ideas that have been stolen by many people, because sharing is a very easy. But encrypted, but it can be shared easily to others. There are many possibilities for other to store our data, especially with technology. And Prof. also mentioned that it is always something very difficult in this kind of situation. But in reality, even though blockchain already available, it is still only used mostly on Bitcoin, for example. But for other purpose, it is, many are still on the discussion and research topic, not in a wide implementation. But for part of research, I think that's okay.
Can I ask? I had another question for you, because I said that I feel that when the amount of data that is available about someone is there, even without passport numbers and things like that, you can be identified. Is that true, or is that a mistake? Oh, it's true. Oh, okay. I can continue saying that. Right. Okay. Good. Right. It remains possible. Yeah.
It remains possible, I think. Yes.
Yeah. Okay.
Because I think, for example, the case of it is also has been discussed yesterday in other class. For example, right now we are also entering the post-truth era, when people share something hoax, fake news, etc. And then the question is how to validate this data. But actually, we can validate this data by the behavior of the person. If, for example, this posting is coming from this kind of group, and then we could compare the similar posting, compare with other group, and then we could validate what are the behavior of this person beyond this posting. So I think finally we can know the characteristic, the validity of the data. And also this is not only about posting something, but also other information, like you mentioned ID. So if we have this kind of, we are talking about social network analysis, because all our part is already connected. Our searching connected to Google, our sharing connected to Facebook. And when we are using social media, usually they are asking what kind of ID that you are using. Finally, it is connected to others. So yeah, it is possible. And I think it is also related to the small word concept. When one's node or one's object, finally, if there are many edge finding out, many connection finding out, finally we know exactly who is this person. Yeah, yes, yeah.
Hanya terpisah dengan 6 orang sampai ke orang yang di ujungnya.
Yeah.
Connected world.
Yeah.
So, ada lagi yang mau ditambahkan? Are we good? So we can wrap up, I think. Yeah, and everybody's hungry, cold and hungry. The room is cold and hungry. Okay, terima kasih atas partisipasinya. Thank you for the discussion and thank you for the expert sharing, Dr. Anis and Prof. Dick. And we hope this can be of benefit. At least is a stimulation for further queries and research development later on for whoever you are in your background. This is for the first half of the day. We can conclude now for ethics in big data, and we shall return and continue with ethics in biobank with our experts from our institution, Prof. Rika and Bu Yaya, PhD, and also still with Prof. Dick, but that's after lunch. So we shall have break now until 1 o'clock, and we will start again at 1 o'clock in this room for ethics in biobank. Thank you for everybody's participation. Oh yeah, photo. So this lady suggests for a group photo. Yeah. Mau diminta ke depan atau dari sini kamu foto? Oh, jadi dari depan kamu foto. Okay. So yeah, if everybody can gather around the center, we will take picture from here. Ada di sana sih. Itu kan
Oh iya.
Mari merapat ke tengah. Paling jauh Bu. So only in the middle. Duduk nggak apa-apa, lenggah nggak apa-apa. Lenggah nggak apa-apa, hanya yang di pinggir-pinggir mohon merapat ke tengah.